Chapter 3, Medical, Legal, and Ethical Issues. The objectives are going to be legal, moral, and ethics of EMS. We're going to discuss consent, advance directives, refusal of care, negligence. We're going to define what a tort is. We're going to talk about HIPAA, COBRA, EMTALA. We'll talk about medical alert tags, how to conduct ourselves on crime scenes. We'll talk about some specific mandatory reporting incidences, and then also safe surrender sites. So EMT credentialing. After you guys finish this class, what is that big test that we have to take? National Registry. So the NREMT is the national governing body of EMTs. EMTs, paramedics, EMRs, and AEMTs. So they create that national standard, national curriculum. Once you get your NREMT, you're then able to apply to the state for your state card. After you get your state card, or for us, our California EMS agency, we can then apply to our county cards. So after you get your state card, you can apply to Riverside County, San Bernardino County, San Diego County, or wherever you guys want to go in the county. And that's how our EMT credentialing works. We have the national standard, the NREMT, the state level, and then your local protocol or county levels. As far as legal duties, the scope of practice, what do you guys think the scope of practice is? Yeah, what we are allowed to do. The NREMT is who dictates what our scope of practice is. And then also our medical directors can make that scope of practice smaller, but they can never go bigger than the national scope. It's kind of like federal law. So we have federal law that creates this large federal law, but your states can have a more strict law, and then even your smaller jurisdictions can have a stricter law. Your scope of practice is dictated by the NREMT, which then can be changed a little bit or be more strict at the state level and then at the county level. The standard of care. What do you guys think the standard of care is? Yeah, so the standard of care is the care that is expected to be provided by an EMT with similar training. So if I go on scene of a call with my level of training and I do something wrong, they're going to judge my actions based off of a similarly trained EMT or paramedic. Does that make sense? So if I were to go and act appropriately or act in a certain way or conduct myself on scene in this way, would someone similarly trained as me conduct themselves in the same way? The duty to act. This is your legal obligation to respond to calls if and when you're on duty. So if I'm in uniform and I'm clocked in as an EMT and I get a call, I have to go to the call. I have a duty to act. So if I'm at Chick-fil-A and I put my order in and I'm waiting for my food and we get a call, I can't wait for my food. I have to go to the call. That's my duty to act.
Did you just lose that money?
That's a great question.
Do they respect it? You're like, oh, you're a firefighter, you can come back?
Yes. So oftentimes I just tell them, hey, or if we're shopping, I say, hey, we got a call. We'll be back if we can. And if we do get back there, we hopefully get our food. I've had cold meals because of that. Also, here's the pro tip. You phone in your order. So you phone in your order, and then you walk in, you're like, hey, I'm Johnny. They give you your food. They ring your meal. That's been one of my things, is I'll phone in my orders to make sure it's set for me. So when I walk in, I can just grab my food so I don't lose it if that happens. Your duty to act. So there was a case somewhat recently where responders were, I believe it was in New York, it could be somewhere else, where they were eating lunch and they were toned out to a call. They didn't go to the call. That person ended up dying, and those two medical personnel were tried because of that, and they lost their licenses. If we're in our vehicles and we stop at a crash scene in uniform, once we make ourselves a part of that incident, we have a duty to act. If we're in our vehicles and we're going from one station to the other or on our way into work and we see an accident, if we don't stop, we technically don't have a duty to act. Does that make sense? Oftentimes, And this is right, wrong, or indifferent. If I have my certain criteria to where if I'm going to stop and help people on the side of the road, if I'm in flip-flops, I will not stop because that's a PPE/safety thing. I'm not going to cut up my feet. And if I have my family or my daughters or my son with me in the vehicle, I will not stop because I'm not going to risk them on the roadway getting hit by another vehicle. If there's other things that may need my assistance, I'm more than willing to help out if I don't have flip-flops on and I'm not with my family. Your Good Samaritan law. This protects a person who is not being paid for their services from any liability by helping out. Now, here's the thing, is if I'm doing the Good Samaritan thing and I break my scope of practice or I break that standard of care, this Good Samaritan law doesn't help me. So if I hop on scene and I do some medical procedure that I'm not trained in, that I watched on YouTube, but it's not my scope of practice, I'm no longer protected by Good Samaritan. Medical direction. The medical director is the doctor who gets to dictate what our scope of practice is, and they allow us to do all of the things that we're doing. The medical director, or as we're working as EMTs in the field, we are acting as agents of the medical director with their oversight in order for us to do the things that we can do. There's something called a standing order or our protocols. These are the things that we can do without calling a medical director. If we have to contact the medical director or an MICN, we can call the hospital and speak to them to try to ask for an order, or if we need any clarification on any treatments, we're able to ask for advice when we call them. This is someone who is always there for us if we need them. Ethical responsibilities. We have ethics and morals. Ethics is the study of the philosophy specifically directed towards morality, and then your morals are what your perspective is on right or wrong. Or who do we get our morals from? Family, parents, societal standards, all of these outside influences. Can someone's right be someone else's wrong? Right? And then can someone's wrong be someone else's right? Yeah, it's kind of to each their own. In my opinion, as far as morals go, if you always put the patient's needs before your own and you do what's right by the patient, you can't go wrong. Does that make sense? Oftentimes, the general public won't know exactly the technical aspects of our job, but they will know and understand how you make them feel at the end of the call. We've had times where we were trying to help people and we bumped off priceless Chinaware or priceless family heirlooms and they've shattered on the ground. And that's one of those ones you're like, oh my gosh, I'm so sorry. Is there anything that we can do to fix this? Can we pay for it? Can we replace it? And oftentimes, if we are kind to them and treat them like human beings, it's almost like a no harm, no foul type of thing. But if I was a complete jerk to them or was mean or was short with them and I did something like that, do you think that they would give us the benefit of the doubt? Absolutely not. So treat them as human beings. Some ways that we can also maintain our morals or making sure that we're not being unethical is we want to maintain our skills mastery. We want to understand the updates that are coming through all of the changes with EMS. Do you think EMS is something that's very static that never changes, or is it dynamic? It's extremely dynamic. Things change all of the time. When I started in the field, our philosophy was if you put a tourniquet on someone, they're going to lose the limb. Now, 20 years after studies overseas, we learned that the tourniquet is an amazing treatment, and you have between 4 and 6 hours before you cause any long-term tissue damage. This is stuff that changes over time. We want to critically review our performance. One thing I want to tell you guys is be ruthlessly honest with yourself. If you did something silly or you could be better, be ruthlessly honest with yourself, because you're going to get to some point in your career where someone's not going to check on you. You'll hit to this point where you're a senior personnel and they're just going to let you do your thing. So it's up to you to maintain that skills and ability and hold yourself accountable. Report everything with honesty. So if you did something wrong, fess up to it. If you didn't get a sugar, fess up to it. If you did something good, fess up to it. This is not just a negative thing. Even acknowledge the good that you guys did as well. And then also work harmoniously with your EMS crews. If you can, let the ego go. Do what's best for the patient in that moment in time. In front of the public, be as professional as you can, and you can settle any differences offline or outside of the public eye. I've had multiple times where I've had crew members where I struggled with getting close to them personally, to where we kind of played this game to where it's like, dude, I can't stand you. I don't want to be in the same room as you. But when we were on scene and when we were on call, you'd have no clue that we were any different. Consent. What do you guys think consent is? Huh? Yes, right? Consent is gaining permission to treat a patient. So under law, the conscious patient has the ability to make their decisions and have informed consent. Informed consent is when I tell you what's going on, that is consenting to those treatments. Informed consent is more common in surgical procedures. I've not necessarily seen informed consent pre-hospital, but what informed consent looks like is, sir, before we do this surgery for you, understand that you could feel numbness and tingling, there could be swelling, there could be adverse reactions and or infection. There's a possibility of not being able to move your limbs anymore after this surgery. But the good side is we can fix you, we can heal you, we make you 99% better, and with a little bit of PT, you could be 100% better. I just informed you of the risks and complications of what's going on with that procedure. I've never been in the back of the ambulance, so I said, sir, can I start an IV on you? I might blow your vein, there could be some bruising, there might be a little bit of pain, it could cause an infection. Is it okay if I do that for you? I've never done that, but I'm like, sir, can I start an IV on you real quick? So by just asking that, and they say yes, you've gained consent. So there's a couple different types of consent. There's expressed consent. What do you guys think expressed consent is? Yeah, help me, right? That's expressed consent. Or, sir, can I help you? Yes, you can help me. You've expressed that you wanted me to help you. There's implied consent. Implied consent is going to be for patients who are not of right sound or mind, or that have an altered level of consciousness. So what implied consent means is that if you were in your right state of mind, you would want me to treat you with all of these things. So if you're unconscious on the ground and you're bleeding from your head, if you're in your right state of mind, you'd want me to stop the bleed and treat you and take you to the hospital. That's implied consent. You have minor consent. Minor consent is for a patient less than 18 years of age. So if they're less than 18 years of age, we have to assess, treat, and transport those patients. So if you have young Johnny driving his car at 16 years old, and I bump another car, and I have no medical complaints, and 911 is called, we have to assess you and treat you and potentially transport you unless we speak to your legal guardian or have a family member come on scene. Now, there's a few people that can consent to themselves if they're less than 18. People who are emancipated from their parents, people who are service members, and then your less than 18-year-old pregnancy patients can consent to the baby. And then you have involuntary consent. These are for those incompetent patients or patients who are in custody of law enforcement. These are going to be your 5150 holds or your patients who were detained by law enforcement. They have no choice in going to the hospital, but they still have their sovereign rights to their body. So if you're detained by the law enforcement officers and I'm like, hey, can I check your blood pressure? And you tell me no, I'm not going to force you into letting me take your blood pressure. You still have the rights of your sovereign body. You just don't have the right to decide whether we go to the hospital or not. End of life care and advanced directives. So these are generally your terminally ill patients. They have a condition that is going to cause them to pass away within the near future or eventually, or these can be those patients that are extremely old that are kind of at the end of the line. There's a handful of different types of advanced directives. There's something called the durable power of attorney or a DPOA. This is when you allow the next of kin or a loved one that makes the decisions for you. So if I, for whatever reason, have a head injury and I'm in the ICU and I have a tube down my throat, my DPOA is my wife. And she's able to make those decisions based for my health care because we've allowed her to be my durable power of attorney. She's that patient advocate. You have a do not resuscitation order. This is a legal document that has to be signed by a doctor that states do not resuscitate. So if my heart stops, we don't do CPR, we don't give them medications, we don't try to bring them back. That's your DNR. And then you have something called a PULST. This is a physician's order on life-sustaining treatment. What this is a form that says, if I die or become sick, please do these treatments or not those treatments. So you can have a do not intubate order. You can have an order that states only pain management or supportive care to make this person comfortable on their way out. It helps dictate what we're going to be doing for them. With your DNRs and your PULST, most states recognize that a family member or next of kin can override the DNR. So philosophically, if I have this terminal illness that I'm going to die, and I have been fighting the good fight, and I'm ready to go, if I talk to my son and I tell him, hey, you know what, I've had a really good run, I'm tired of this, I'd like to go to the doctor's tomorrow and get my DNR signed, but I don't have any legal documents. If for whatever reason that night I code and the crews come out to treat me, my son can say, hey, I just had a conversation with my dad. He doesn't want to live anymore. We talked about doing a DNR with him. Can you guys please just let him go in peace? We are obligated to start basic life support CPR and contact medical direction. When we contact medical direction, we'll tell the medical director or the MICN the situation, what's going on, and we can try to leave that patient with that family member with their wishes and hopefully call the code without doing any invasive stuff to disrespect that family member. But it also works the other way too. Say I do have a DNR and it's signed by a doctor and I was like, you know what, I'm over this, I'm ready to die. And then I have this moment of clarity or this moment of change where I talk to my son again and tell him, hey, I know that I have a DNR right now. I really want to see if I can fight this thing through. I think I got a few more months in me. Let's see if we can beat it. And then I code that night and the crews come out. And my son tells you, hey, just so you know, I talked to him. He wanted to get his DNR lifted. Is there any way that you guys can please work him? We can also do that as well. So in that moment in time, based off the patient's wishes, the family's wishes, we would work the code. Any questions?
What happens if you didn't give it and they were just like,
you shouldn't. That's like one of those ethical things to where if it feels right, it probably is. And if this is what they're wishing to do, let's listen to the family with their wishes. There are those kind of weird tangents to where dad wants to die and he dies, but then family member don't want to let him go. In that point, because I haven't spoke to dad, I would probably still acknowledge the family's wishes and work the code. Now here's the gray. What if you bring dad back?
yeah, he wakes up.
It's like, what the heck? Like, I was ready to go. You sons of guns.
Yeah.
That's a weird gray area. But I would say acknowledge the living and do what they tell you because they're probably not lying to you. I hope. If you can't find the DNR, like, hey, he has a DNR, we can't find a form, once again, we would just start BLS CPR and contact the medical director. And just the same thing, hey, they're saying that this patient does have a DNR, it's signed by a doctor, they can't present the form, we're looking to call the code. And the reason why we contact medical direction is we take the legal responsibility off of us and put it on the hospital. So it's not I'm working as a rogue agent, I've contacted a higher level and they help me with this moral ethical decision. So if patient refuses the care, this involves massive legal, ethical, and moral decisions. The patient must have the capacity to make their decisions. So they have to be oriented and they have to understand the magnitude of the situation that's going on in order for them to AMA or sign an against medical advice. So an against medical advice, these are those documents that we sign if the patient is refusing to go to the hospital. Bless you. There are a few things that we have to document. We have to document who and why 911 was activated, so the patient and their chief complaint. We have to talk about all circumstances pertaining to consent issues. Are they able to consent for themselves? Are they in that right state of mind to make this correct decision? We have to talk about any presence of drugs or alcohol. So is this patient inebriated? Can this patient make good decisions? Is having 2 beers drunk?
No.
Not necessarily. Is having an 18-pack drunk?
No.
Not necessarily, right? Chances are you're probably not making great decisions, unless you're making great decisions. But if the crews are there, you probably didn't make great decisions. But we need to understand, is this the case where dad had a couple beers while he was barbecuing and burnt his hand? Or did Uncle Johnny have a ton and he jumped off the balcony and didn't land in the pool? So what are these consent issues? The patient has to have all risks and complications up to and including death described to them. We have to talk about the reason for the AMA and the patient's plan. So the patient plans to follow up with his primary care physician tomorrow. The patient plans to go to the ER via private auto. So what is their plan once we leave? We have informed the patient that they can recontact 911 at any time. So that's something that we tell them. If this gets worse or you feel different or you need to, you can recontact 911 at any point in time and you have the patient sign your AMA. One thing I would recommend to you guys as new clinicians is I would not AMA someone for probably my first 2 years. Even as a medic, I would not AMA someone for probably my first 2 or 3 years. And that is because you need to understand what sick looks like and what sick doesn't look like. And the only way that we do that is transporting everyone and seeing those disease processes over the hour that we're with them. And that will help you decipher who is sick, who isn't sick, who needs to go, and who doesn't go. Now, if you're the EMT and you have a medic partner that's like, dude, can you just AMA him so we can leave? Once again, advocate for the patient if they need to go. Encourage your medic partner to take them. Your mileage may vary on that one, depending on your partner, but always err on the right side of the patient. So negligence. Negligence is the breach of the standard of care. There's something called simple negligence, which is doing something slightly incorrect or not doing something that should be done. And there's gross negligence. It's the willful, wanton, extremely reckless patient care, far beyond being negligent or careless. So if I have a patient who is in a car crash and I assist them out of the vehicle and I forget to put a C-collar on because they have neck pain, that could be simply negligent. If I have that same person who's in that vehicle with neck pain and I rip them out of that vehicle and they become paralyzed, that could be grossly negligent. Does that make sense? Because I was doing something that was so heinous and reckless that I caused harm to my patient. Versus the first one, I tried to be as careful as I could. I tried to do my procedure as well as I could, and I overlooked one little thing. And there's something called proximate cause. Proximate cause is when we can decide or prove that the injuries caused to that patient is because of what we did or didn't do. So for that second example, when we ripped that person out of that vehicle, there's proximate cause that that patient wasn't paralyzed before we pulled them out, and that they were paralyzed because of our actions by pulling them out incorrectly.
So if you have like a patient with like a neck injury come across in a car, would you first like ask them if you feel any pain in your toes just to make sure that he's paralyzed?
Yeah, so if we have that patient who's in the vehicle, first thing I'll do is I'll delegate C-spine to my partner. And my partner will go in behind them. And if we can, I'm going to try to approach you from the front of the vehicle and say, hey, sir, can you make sure you're looking forward? My partner's going to hold your neck real quick. And then we're going to get behind them and hold C-spine. And then I'll do my orientation questions, do like a quick CPS assessment. And what I like doing is, Evan, can I touch your head? See that? That's express consent, right? So I would say, hey, sir, does this hurt real quick? And I'm just going to palpate his head and his neck and say, hey, go and squeeze my hands. And then can you wiggle your toes? And then I just established that there's no head, neck, or back pain. He has good CMS. He can wiggle his hands and his fingers. So he's not paralyzed to this point. Does that make sense? That's how I would approach most of those things. And it's one of those things to where you're absolutely correct. You're going to do that quick assessment, that down and dirty, head, neck, back, chest, abdomen, and fingers and toes, just to make sure that there's nothing that's going to hurt them immediately. And then we might be able to slow down. So your breach of duty of act. You can be held either criminally liable or civilly liable. What does criminally liable mean? It can be state, it could be federal law or local law, but being criminally liable means that you're going to face jail time, right? So I believe it was in Colorado. They had a patient who was having a excited delirium episode. This person was having an excited delirium episode. They ended up placing this person prone, so face down, and gave them a bunch of ketamine. The patient died because of it. These two clinicians are being trialed criminally, and they're facing jail time because of their decision. Because it was grossly negligent to give them that much ketamine and to lie them face down. And then there's also civil liability. Civil liability is when you guys are being trialed for money. Generally, as clinicians, they're probably not going to go for your house. They're going to go for the big pockets of whatever organization you work for. Can they go for your house and your money? Absolutely. There is malpractice insurance for EMS personnel. If that's something that you're wanting, might be something to look into. But in order for them to trial you civilly, they have to prove 4 things. They have to prove that you had a duty to act. They have to prove that you breached your duty to act. They have to prove that you caused injury or you had that proximate cause of what you did harmed the patient. And they also have to say that there was injury was a result of the breach of duty. A tort. A tort is wrongful act or injury or damage. There's intentional torts. What do you guys think abandonment is? Leaving them, right? It's an intentional, it's leaving the patient. Most instances of abandonment happen at the hospital. We have to render care to someone equal or higher than us. If I bring someone to the hospital and we're holding the wall and I'm out cleaning the gurney and a fire pops off in the city and I'm like, hey, everybody, we got to go, man. Like, there's a fire, let's go, right? And you're like, all right, cool, later. Like, we're good. We abandon that patient. Does that make sense? We have to render care to the staff so we don't abandon our patient. What is assault? Assaulting is saying I'm going to punch you in the face. It's a verbal act of violence where I'm capable of doing it. Battery is when you actually go punch them in the face. So assault is, if you don't do this, we're going to hogtie you. Battery is when we actually hogtie them. We don't hogtie people. It's an example. False imprisonment or kidnapping. We cannot kidnap people. So if someone's sitting in their house and we're like, sir, you need to go to the hospital, and they're like, no. We can't grab them and steal them from their home. As long as they're oriented and of sound decision to make those decisions. Does that make sense? Now, there's a couple verbal judo things that we can try to do. And I could be like, hey, sir, how about you let me take care of you? Can you please just stand up and sit on my gurney? And he gets up and sits on my gurney. He did it under his own power. But if I'm like, hey, sir, can we please help you? Can you just sit up on our gurney? He's like, no. We can't force him to go if he doesn't want to go. And then also there's defamation. We can't just talk badly about people because of people. You can't be like, oh my gosh, did you hear about Miss Smith? She called 911 17 times. She's a horrible lady because her cats pee everywhere and she's always sick. We can't defame their name or have any defamation of character. HIPAA. It's the Health Insurance Portability and Accountability Act. Health Insurance Portability and Accountability Act. What HIPAA is, it protects patient privacy. It originated as a really, really good thing to protect people from getting bills and to protect them from their information being sold from the hospital. But this protects their confidentiality, and we can't disclose any intimate or personal information from the patient. If we have our school PCRs and you guys write Johnny Appleseed, birthday 3/27/45, home address 1234 Corner Street, Oceanside, California, that's patient intimate information. If that PCR is left here and we have an audit, that is a $10,000 fine for every PCR like that. So when I tell you do not put patient information on our PCRs, do not put patient information on our PCRs. That's the same thing with your patient run reports with your facilities or whichever agencies that you guys get to. Say that you have a stack of patient reports with all the patient information and you leave it in an unsecured ambulance that's not locked up and that information gets audited. That's $10,000 per PCR or document that's in that stack that could be audited to that organization. So please be extremely careful with your patient information. That is a huge violation. Your COBRAs and your EMTALAs, these were designed for patients that were being dumped or shipped off to other hospitals. It originally, if I don't have the correct insurance and I walk into the NICE hospital says that I can't afford their care, they would just ship me off to county, where county would eat the cost for me. What these two laws state, that is if you are at the facility, they have to stabilize you and treat you before they can transfer you. This was super common with pregnancy patients. So this is why every time you go to a hospital, it says you have the right to be treated here if you're pregnant or any of these other things. So they have to stabilize you before they can transfer you, so they don't just ship people that can't afford their locations. This is more on HIPAA, 1996 federal law that protects the privacy of potential healthcare information. You're limited to discussing the patient-specific information. So I can't have an identifier of the patient's name, the location, generally the time of the call, or any information that can be brought and identify a single person. So most of the scenarios that we give you are probably patients that I may or may not have seen, but you cannot identify them. So if I tell you a 72-year-old male with chest pain, you can't identify them. But if I tell you it's Mr. Johnson, he had chest pain last night, that is that violation of HIPAA. Or I could even say, hey, we went to this house off of Cornerstone last night. That is patient information. I can't tell you birthdays or anything that can identify a human being. You're required to gain a patient signature stating that you are acknowledging their rights as a patient for all their HIPAA stuff. Medical alert tags. What do you think the benefit of a medical alert tag is?
They're unconscious. You know, they have like diabetes.
Yeah, if they're unconscious and they have a medical alert tag, it kind of tells us what could be the issue. This is going to be more common with your chronically ill patients. It can also show you allergies, our diabetics, seizure patients, anything that could potentially make them unconscious. They usually have a medical alert tag. Also, there could be medical alert tattoos. So you could have diabetic tattooed on your forearm or seizures or something like that to let responders know if they find you. If you have DNR tattooed across your chest, it doesn't count unless the doctor signed it. Just kidding, it doesn't count. But you could have a DNR bracelet and they would still need to present you the DNR forms. Does that make sense? Obvious signs of death, BR dead, burns, so if a human body is completely incinerated, rigor mortis, which is that stiffening of the joints. Your rigor mortis is most common in the jawline. So anytime that we go on to a code or a CPR status patient, my first move, I'm going to touch the jawline. If the jaw is stiff, they're considered to have rigor, and we don't work that code. You're going to have decapitation. So if your head is chopped off, and the brain is no longer speaking to the body, that is an obvious sign of death. Evisceration of the heart or the brain would be considered an obvious sign. Decomposition. So we are organic organisms. If we're no longer perfusing, our body begins to break down because of all the lactic acid and myoglobins, so your body can actually decompose. If you see that, that's an obvious sign of death. Some protocols state blunt traumatic arrest with asystole. So if we go to a car crash and someone's in a code status, we can put the monitor on them. If their heart is flatlined, they're considered coded. And then also sometimes lividity. Lividity is when someone has been dead long enough that their blood pools where gravity takes them. And there's going to be this line of demarcation wherever the line is. So if someone is lying flat, it's going to be along this mid-axillary line. If someone was seated or slumped over, it's going to be wherever the blood pools. And you're going to have kind of a redness on that lower side and a pallor or a paleness on the upper side. Crime scenes. Why do you think it's important for us to be aware of crime scenes? Evidence. What can we do as providers to disrupt evidence?
Move the body.
Move the body.
Clean the body.
What was that?
Clean the body.
Clean the body. What else?
Remove clothes.
Remove clothes, move weapons, shift stuff. So if there was a fight in here and you can kind of see how the fight went based off of all the stuff, if we come and just move everything, we've ruined that crime scene. So for us, if we can, we're going to go one way in and one way out. We're going to send as few people as needed to get into the scene. We're going to try to move as few things as possible. If we need to take note of some things, take note of them, but try not to move them. If it's an assault with stabbing or shooting, if we can, let's cut around the holes, not through them. On my shootings and stabbings, I like going down the seam line just because you leave this front portion intact. If it's a sexual assault, we're going to encourage the victim to not shower, and if they can, to not change their clothes, just because we don't want to disrupt any of the evidence that could be collected from them. If we are collecting evidence for whatever reason, we want to place anything that they have into a brown paper bag. And the idea is a brown paper bag, air goes through it, so everything in there will dry out and we don't create any new organisms or any new types of evidence. Versus if we put it in a plastic bag, the plastic bag holds moisture, and that moisture creates organisms or little. If they hang themselves, don't cut through the knot. Try to cut the rope itself. Mandatory reporting. These are the cases or incidents that we have to report. Any forms of abuse, whether that's pediatric or elder abuse. For pediatric patients, we're going to contact Child Protective Services. For older patients or adults, we're going to contact Adult Protective Services or APS. With these cases specifically, we have to all file a report. If I'm suspecting child abuse and I'm the transporting unit and I file a report, there's going to be one file in that kid's report. It's probably not going to get flagged. But if I'm on the ambulance, you're on the fire engine, one of you guys are in the hospital, and then another one of you guys are in the law enforcement agent, if we file 4 different reports or 5 different reports, that will then get flagged for it to get reviewed. Does that make sense? So everybody does their part when we're filing reports for child abuse or elderly abuse. Crime scenes or suspected crime, we have to report that to law enforcement agencies, and any drug-related illnesses or issues, we try to report that to law enforcement and or a case manager at the hospital. Addiction is an illness. It's not a crime. And then we have these baby safe haven sites. So in the 1990s, there were mothers that were thinking that they weren't able to take care of their children. So when they gave birth, they would throw their babies away. Thus the term a dumpster baby. Because of that, a new law came into place called the Safe Haven Law. The safe haven law is if your child is 72 hours or younger, you can drop them off to a safe haven. That is going to be a fire station, it's going to be an ER, or a police station. And when you drop them off, it's a no questions asked. We accept your child. We're going to put a bracelet on the baby that has a number. We're going to give the family member a bracelet that has the number. And I believe they have up to a week to reclaim their child. In that moment in time, if you ever have that situation, try to gather as much information from the parent as possible. And it doesn't have to be their name, phone number, and where they're located. What we're concerned with is medical information. Do you guys have any family history of cardiac illnesses? Do you have any chronic conditions that run in your family? Was the baby a full-term delivery? Was there any complications with the baby or child during delivery? Any history of alcohol or drug abuse? As much information that you can gain for them, because that might be the only information that child has moving forward in whatever foster cares or next levels that life takes them.
What do you do with the child?
So if we're at a station, what we were trained to do is we will activate a response, which will put us on a call type. So we'll call our dispatch center. We'll tell the dispatch center what's happening. They won't tone the station, but they'll attach us to a call. And then we accept the baby and it becomes a patient. So we'll do a patient contact, patient care report, and then we're going to take them to the hospital. And then we'll render care to the facility staff there, who will then get them set up with a case manager and hopefully into foster care. So in conclusion, we talked about the legal, moral, and ethics of EMS. We've talked about consent. We've talked about advanced directives. We've talked about the refusal of care, negligence, what a tort is. We've touched base on HIPAA, COBRA, and PALA, medical alert tags, crime scenes, mandatory reporting, and safe surrenders. Any questions?